So Professor Bertsimas is the Boeing Professor of Operations Research and Associate Dean of Business Analytics at the Sloan School of Management at MIT. His research interests include machine learning, optimization, and their applications in healthcare. He has co-authored more than 250 scientific papers and 5 graduate-level textbooks. He has supervised 76 doctoral students and is currently supervising 25. That's quite a cohort. He's a member of the National Academy of Engineering and recipient of the John von Neumann Theory Prize for fundamental contributions in operations research and management science. And since March of last year, he's led a group of 30 doctoral students, postdocs, and professors to study multiple aspects of COVID-19. So Professor Bertsimas also spoke in the C3DTI Colloquium series, and we're really glad to have you here to present an update on your work.
Thank you very much. Good morning or good afternoon, depending on where you are in the world. So this is an effort that would not have been possible without the collaboration of a large team of quite a few talented young people who you see here. So there are 3 areas that we have discussed, we have focused on. An epidemiological modeling, a model we call Delphi. Differential equations lead to predictions for hospitalization and infections. That has been part of the CDC Ensemble Model and has been used closely with Johnson & Johnson to guide the choice of sites to do the clinical trial. In fact, J&J is about to announce the results of the 1-dose trial later in the month, I'm told, and we are still working with them on deciding sites for the 2-dose trial that is ongoing. We have also, it has also been used, as I will indicate, with the Hartford healthcare system to size the ICUs and also various other resources, ventilators and so forth, earlier in the disease and also in the fall that has been an ongoing. We have also extended the model for allocation of vaccines. The idea would be if we have a model that decides, has a prediction about the future, how to optimize who gets the vaccine first. Of course, that also has fairness characteristics. We made an attempt with the previous US administration for that, not particularly successful. Hopefully, we might have more success with the current administration. And finally, we have worked on clinical scores. This is is currently in use in Spain and in Italy for triaging patients regarding ICUs and understanding the severity of disease for COVID-19. Our work, a paper that we have written, was awarded first prize in the Informs competition regarding healthcare. So let me talk briefly. I have little time. So and all of our work, is on covidanalytics.io. We have daily predictions. You can look at that there if you are interested, and also codes and papers. All of our work is public. So in terms of the background of epidemiological models, and I know in the audience there are people that have expertise on the matter. Our effort has started, I remember the day, March 16th. This is when we had our first meeting. So all of our efforts that I'm about to say has been going on from that time, about 10 months. In the beginning, we have data sparsity is, of course, much more data is available. We wanted to also capture human intervention, and there's a lot of parameter sensitivity. These are models that have parameters. Our basic starting point is the compartmental epidemiological model that people know. This is sort of epidemiology 101, where you have susceptible, exposed, infected, and recovered. And you have this nonlinear model who has some parameters to estimate. This is sort of the basis. We augmented that because there is under detection of a disease, and we would like our model to capture it. Also, we would like to model the societal response through nonlinearity. And I'll tell you that's an important component of our model, how to capture, in a way, a societal response or government response in the effect. Our model consists of 11 states: susceptible, exposed, infected, um, undetected, hospitalized, and then two categories: recovered and diseased. It's a system of nonlinear ODEs that has unknown parameters, unknown, and there are things that we estimate and things we observe. We observe from papers. And a very critical parameter is the infection rate, alpha, uh, which is the average number of people, as the definition, the average number of people each infectious person would infect per day. Um, the classical model assumes a constant rate. That's not correct. It's not appropriate to model that. Would not lead to fantastic predictions, and it's affected by measures like social distancing, mask wearing, or stay at home. So instead, we model it as a function that has this particular form. It's hard to understand. Let me give you a graph. So the idea is we utilize a slow varying function of time that tries to capture how society and individuals respond to the four phases of government intervention. In the first phase that you see here, the initial response, the rate of infection decreases, but not very fast. The awareness of the population is relatively low. This is particularly relevant in the beginning of the disease. We have seen this early in, let's say, March, April timeframe. Phase two, it's a much sharper decline in the infection rate as policies are now instituted and lockdowns perhaps are being announced and implemented. Phase three, there is some saturation aspect of the policy effect that is representing my diminishing marginal returns. This is sort of the convexity that you see in that portion. And then the final is the resurgence, something we have seen in the early fall, in that of some magnitude that we estimate due to the relaxation in the restrictions and social behaviors. So, as you realize, we develop this model and adjust as the disease is going on. I mean, we have, they are, to the best of my knowledge anyway, there have not been results in the literature that are adjusted as we go on. So this is the model we utilize, this part of the model, we utilized it in the spring, in the summer period, in early fall, and we adjust as we go because there are different behaviors. And of course, the timing of all this, of course, is different depending on different how the policies have been implemented in various parts of the world. Our model is estimated every day with the 50 US states and about 120 countries of the order of 200 places in the world that we and then when we talk about Johnson & Johnson, we do it at various not only at the state level but at the counties level around the countries that they have particular interest. So altogether we might be estimating several hundreds of places in the world at a daily level. So, and there are, as I mentioned, there are 11 states, and only 4 quantities are observable: the detected cases, recovered cases, death, and hospitalizations. And hospitalizations, generally speaking, are not, the data on that are not fantastic. They are sporadic, they are not always available, and somewhat unreliable. On the other hand, there are not, we do collect some of these, we have them. And then what we do is that we utilize, we have a nonlinear set of equations that has some parameters. So given a set of parameters, we can predict a curve. We have now data that that we run it against. So on a daily basis, we adjust some of the parameters slightly. The parameters do not move very fast and we utilize truncated Newton methods and often simulated annealing for more global convergence to estimate the unknown parameters. And we do this for every place that we where we make predictions. So and in trying to minimize the overall mean square error of the both on cases as well as deaths. So if you want to learn more details of what we do, I would like to invite you to take a look at our website where our codes are available to see more detail of what we're doing. The model generally, this is in the early phases, has done quite okay, has done well. Its error historically from June until now, this was early stages, the previous slide. Now it's in the number of cases, we are in deaths, we're under 10%, and on cases on the place, we are between 8 and 16%. And in terms of projections around the world, you see at various places, similar to the United States, in some places like Europe, the results are stronger. In some places like Africa, it might reflect the quality of the data, less strong. As you know, the CDC announces, our model is part of the CDC Ensemble Model, and this is the ranking of the model over weeks over the summer until late September. And the blue is our model. It has sometimes it has been the best among the ensemble models, sometimes not, but overall among the better performing ones. So and achieve that, something that is that we have been on top of the model, trying to, because we are applying this for many places, not only the United States. We have, and because also we have been supporting an industrial partner that has a large group that has been giving us feedback on the quality of the model on a daily basis. So we have been on top of the model to update and so forth. And all these new characteristics that we have added have been really because of the feedback we have been receiving both from J&J as well from our friends at Hartford Hospital. I have already mentioned how the model has been used at Hartford Healthcare. It is being used also as we speak, in that especially with the resurgence in the fall, we have seen there's a critical question: how many ICU beds should they have in terms of capacity? And in earlier times about ventilators, I told you about the J&J portion of the development for the COVID-19 vaccine. And also we have utilized it for a large financial institution in South America to guide the policy about their employees returning to work or not, depending on the intensity. So these are some of the applications we have done. Just to give you the effectiveness of the model, this is from J&J. This is the blue is the light blue and the dark blue is the incidence, the proportion of sites above what's called vaccine protocol incidence. So these are places. So we selected places and they started the trials, and these are from real data. And the white are the ones that the model did not select. And you observe that while not perfect, the model did a good job of guiding the choice because J&J had the problem in the past that you can, because it takes quite a while to arrange the clinical trials, including thousands of people. So the key here is not to go to places that are today have high incidence. The key is to go to places 3 months from now, months from now, where you are expected to have high incidence, so that you have enough people to base the clinical trial. And the model has done, I would say, quite a good job in selecting the people. And when I say the model, it's really a model that is evolving evolution of the disease. Clearly, we don't have, this is an empirically oriented research, not that we have a theoretical model, how the physics of the to what we see, and we try to do it globally, utilizing data from a variety of sources around the world. In terms of government interventions, we all have been in recent discussions with 2 governments in Europe regarding what type of policies to to institute no measure, restrict mass gatherings and businesses, gatherings and schools, and so forth. I don't have time to talk about all of this, but all of this is described in our website. You can take a look. We estimated the effect using data. Have no measure the infection rate, let's call it 100%, but if you restrict mass gatherings, then the infection rate decreases, and so forth. You see the effects. These are estimated from data. And then when we know that, then we can also ask what if scenarios. And the what if scenarios are unfortunately quite impressive. This is an example that if we went into lockdown a week earlier in New York, we would avert maybe 80% of deaths. That's a sizable, that's an significant number. So early action in this exponentially moving disease matters. The same is true in Europe and so forth. Regarding of allocation of vaccines, and I know I have very little time. So the idea is as follows. So we know that mortality rates depend on age dramatically. Above 80 years old, the mortality rates of the order of 14%, between 70 and 79, 8, and so forth. Infection rates vary between regions. So the question is, if you have an environment like the United States and you have limited vaccines available, the question is how many vaccines to allocate in each age group, in each state, on each day, having also fairness conditions, namely that you have a representation of the population of some similarity between states, and the number of deaths to minimize the total number of deaths under the constraints that you have epidemiological dynamics, which is our model. You have resource constraints, you have limited supply, as well as fairness requirements, and also you have vaccine limitations. Of vaccines are the same, and we also have multiple types of vaccines. The Moderna vaccine is of the order of 94%. The AstraZeneca and J&J vaccines that are hopefully coming, there might be less than that. So to make the long story short, we have found the key idea is that if you allocate not so. What I understand is for healthcare workers and then older people. That's sort of the policy. So our mechanism allocates not. You can give priority to that as part of the fairness constraints, but to give priority to people that can infect others faster. So that's the key aspect of it. And by appropriately optimizing that, you can actually, we've done some experiments. Of course, these are experiments that are simulate experiments, not real experiments, but that it could decrease mortality of the order of 23. Key here is the idea is to not be static in your allocation, but you also allocate still having fairness and efficiency constraints, but take into account the dramatic differences in the mortality rate in death, and also the way who transmits the disease more or less. I have also clinical risk scores. It's the gist of this is the following: is that imagine that we have data from hospitals. A person comes. You would like to understand, given the symptoms, the probability of mortality and the probability of ICU utilization for the person. By applying appropriate machine learning methods, we have in our website a mechanism, various calculators that you assess. As I mentioned, it's currently being utilized in hospitals in Italy and Spain for triaging patients that arrive. In fact, our model has been updated to account for this disease. The reason you need also relatively frequent update of these models is because with new variants available, the dynamics of the disease change in terms of what is more risky, who is at a higher risk, and so forth. So that's roughly what I have, and you can find more information in our website. Thank you very much. And I apologize if I want a little bit longer.
No problem. Thank you. That was a really interesting and provocative discussion, and to really appreciate all of the research that you and your team are doing.